Hi guys, my name is Didi Jimenez, and today we're going to go over abnormal pacemaker activity. So where do we start? When damage to the SA node occurs, the AV node takes charge. In this case, blockage between the atria and ventricles leads to the ventricles taking control of their own beating, thanks to Purkinje fibers, and not the SA nodal rate. At this point, the atria just beats at its normal rate of 70 beats per minute. To get a clear understanding, let's take a look at the example the book gave us, which uses this picture here that you can see on the slide. In this scenario, we have the SA node, which is the lead engine, Purkinje fibers, which are the slow third engine, atrial cells, which are the rest of the car, and lastly, the AV node, which is the second engine. Okay, so when the SA node, aka lead engine, disconnects from the Purkinje fibers, our slow engine, third engine, and the atrial cells are other parts of the car, because the AV node broke down. This causes all the parts to slow down except the SA node, which continues at a normal pace. Okay, now let's take into consideration that between the atria and the ventricles there is conducting tissue that when it's damaged and non-functional, it results in a complete heart block with the ventricle only beating at 30 beats per minute. An individual normally becomes comatose, considering that at this rate, a sedentary existence is the only amount that can be supported. Fortunately, an artificial pacemaker can help with an abnormally low heart rate, aka SA node failure or heart block. Now, what exactly is this? What does it do? This device creates impulses that reach every point in the heart in order to aid the atria and ventricles in reaching 70 beats per minute. Although extremely helpful, complications can also occur because overexcitation and depolarization of Purkinje fibers can result over the SA node. In our engine scenario, this would be the lead engine being surpassed by the slow. With this comes ectopic, aka out of place focus, which is the initiation of an action potential that extends throughout the heart, which occurs before the initiation of the normal action potential. Because of the SA node, contraction occurs, a premature ventricle contraction. If the rapid rate of ectopic focus discharge continues, the SA node pacemaker activity changes to the ectopic focus. Acceleration of the heart rate occurs and continues for some time until it reaches ectopic focus regulation. This normally happens due to too much nicotine, caffeine, or alcohol, anxiety, or lack of sleep. Why is all this important? Let's take a look at a case study of an unusual pacemaker syndrome and what happened. In this case, we have a female that is 87 years old that came into her doctor with complaints of dyspnea and fatigue on week 1. It is important to know that this patient, 2 weeks before, underwent atrial lead revision of her dual chamber pacemaker because of atrial lead failure. With this, the patient underwent examination and there was no acute distress, a regular heart rate, normal blood pressure, normal respiratory rate, and no distended veins. Here we have our electrogram on the left that shows a steady ventricular rhythm of 70 beats per minute. Because of visible retrograde, it was believed that the pacemaker malfunctioned. In order to check this, intracardiac electrograms were taken, which are shown on the right. And this showed atrial and ventricle rhythms occurring independently and simultaneously. In the first one, there is noticeably large amplitude in certain sections, which match with the P wave retrograde that were on the electrogram. The other rhythm has a smaller amplitude, taking out the idea that it could possibly be an atrial tachycardia. So let's continue. The next examination was for sinus rhythm and eccentric AV conduction, which was done after programming the pacemaker to AAI at 30 beats per minute, resulting in sensitivity of the atrial lead decreasing. Now, taking a look at our long diagram on the top left there, we can see an interrogate AV conduction accompanying sinus bradycardia. Looking at this EGM, Once again, atrial tachycardia was ruled out because it was no longer recognized by the pacemaker. Sinus bradycardia was recognized on the surface ECG, which is our pink diagram we can see right here in the middle on the left. This bradycardia is accompanied by intermediate atrial pacing coexisting with atrial tachycardia. So we finally see our AT, our atrial tachycardia. Under our pink diagram, we have a blow up of it showing the lead V3 that shows a better picture of it. And we can see the atrial tachycardia with the arrows demonstrated there in the picture. Does this look familiar? Well, it should, because it correlates with the cycle length that we saw on the intracardiac EGMs. Obviously, with all the diagrams, there is the fact that atrial tachycardia was small in amplitude, which resulted in researchers decreasing atrial sensitivity in order to ignore AT, which subsided the patient's symptoms right after. With this, the patient was put back on amiodarone and asked to come back and surprise the doctors with atrial tachycardia no longer being present. So now let's go over the results. Okay, now moving on. Earlier I said results, but I meant our conclusion, our final points. So because of the patient's loss of AV synchrony, it was concluded that pacemaker syndrome was in fact what the patient was experiencing. So what triggered it? For this patient, it was an improper switching of modes, which led to AT being electrically isolated. Fatigue, shortness of breath, palpitation, lightheadedness, to syncope, and even heart failure are all symptoms of pacemaker syndrome. Because of this diagnosis, dual chamber pacing was conducted because it has shown to reduce the syndrome. Now, I have no idea if this is still the case, but this report was the first to result in AD due to pacemaker syndrome, which is extremely interesting. So, our conclusion is that the intracardiac AT amplitude signals were below sinus signals. This study found that changing the sensitivity of atrial leads can give us a solution to improper switching between modes of a pacemaker. We have finally reached the end of the presentation. Here are the resources I used in case you want to go over our textbook, and then the case study that I found, which was extremely interesting and went very more in depth than I did, but there it is in case you want to look further into it. Thank you guys again, and I'll see you guys on the next one.